Very good morning to all of you. I'll be presenting our study on impact of taping the upper mask edge on ocular surface stability and dry eye symptoms. My co-authors are Professor Jeevan S. Tityal, Dr. Sridevi Nair and Dr. Ramkishore Saha. There are no financial disclosures. So face masks, as we all know, have become the norm in the post-pandemic era, and the widespread use is associated with mask-associated dry eye, with symptoms such as redness, discomfort, tearing, and foreign body sensation. And the long-term use of face mask has an adverse impact on the ocular surface parameters, especially in occupations such as ours that require prolonged use of face masks, and patients with pre-existing dry eye also have an aggravation of symptoms. The poor fitting of the upper mask edge results in leakage of air towards the ocular surface, which aggravates these symptoms. So the rationale of our study was to study the impact of sealing the upper mask edge on the ocular surface stability and dry eye symptomatology amongst healthcare workers who regularly used N95 masks. It was a prospective interventional pre-post study conducted at Dr. RP Center for Ophthalmic Sciences. The study population consisted of healthcare workers employed in a tertiary eye care center, and written informed consent, of course, was obtained from all participants. A sample size calculation was performed using an effect size of 0.4, and for a power of study of 80%, a minimum of 49 participants were required. Only the right eye measurements were used for analysis. All consenting individuals above the age of 18 years without any pre-existing dry eye disease were included, and any history of topical ocular medication used within the past 3 months or any comorbidities were an exclusion criteria. Contact lens users were also excluded. So the dry eye symptom score was assessed, visual acuity and ocular surface tests were performed. Pre-taping, the visual ocular surface parameters and symptom score were evaluated. At the end of an 8-hour shift, during which the healthcare worker did not seal the upper edge of the mask, the post-taping assessment was performed after sealing the upper edge of N95 mask to the nasal bridge for an 8-hour shift. All participants used the same model of the mask. All measurements were taken between 5 to 6 p.m. in the same room, controlled temperature and humidity conditions. So the symptom score assessment was performed using OSDI and SANDE 1 score pre and post intervention, and SANDE 2 score is only for post intervention. Non-invasive tests were performed at an intervening gap of 5 minutes, including the non-invasive tear breakup time, tear meniscus height, tear lipid layer thickness. Invasive tests were performed at an intervening gap of 15 minutes, including Schirmer 1, corneal and conjunctival staining, and tear osmolarity. The primary outcome was a change in tear film stability assessed by a non-invasive tear breakup time. Secondary outcomes were change in symptom scores, lipid layer thickness, Schirmer 1, ocular surface staining, tear meniscus height and osmolarity, and any change in uncorrected or corrected distance visual acuity. Statistical tests were performed as appropriate, and the mean age of the cohort was 26.7 plus minus 3.67 years. What we observed was a significant increase in non-invasive tear breakup time after taping. There was no significant change in the ocular surface disease index or the SANDE 1 score. The mean SANDE 2 score post-taping was 9.89 plus minus 4.95. 68% participants reported a decrease in frequency and severity of symptom. Median score for change in frequency was -7 and for change in severity was -8, which indicated a decrease in severity and frequency of symptoms with taping. There was a significant increase in tear lipid layer thickness, tear meniscus height, and a significant decrease in corneal staining score after taping the upper mask edge. There was a significant decrease in tear osmolarity. No change in Schirmer 1 score was observed, and the conjunctival staining score was also not significant. No significant change in uncorrected or corrected distance visual acuity. A correlation analysis was performed of the ocular surface parameters with the subjective SANDE 2 score, and the change in lipid layer thickness, non-invasive and invasive tear breakup time, and the tear meniscus height positively correlated with the change in symptom frequency and duration in the SANDE 2 score with a significant p-value. There was no correlation with conjunctival or corneal staining and Schirmer 1 with the SANDE 2 score. So just to summarize, the significant increase in non-invasive breakup time, tear breakup time, lipid layer thickness and tear meniscus height, and a significant decrease in corneal staining score and tear osmolarity was observed after taping the mask. 68% subjects reported an improvement in symptom severity and frequency after taping the upper mask edge, and this change in ocular surface parameters showed a significant correlation with the SANDE 2 score. The primary mechanism for mask-associated dry eye is the mechanical desiccation of the ocular surface caused by an inadvertent airflow towards the eye, and the steady flow of warm exhaled air has an adverse impact on the tear film homeostasis and causes increased evaporation. Risks of increased dry eye in patients undergoing mechanical ventilation and CPAP mask is also a similar mechanism. So this leads to a vicious cycle of increased dry eye related symptoms, inflammation and tear hyperosmolarity, evaporation. So sealing the upper mask edge leads to a definite improvement in ocular surface parameters and dry eye symptoms, and treatments regarding the augmentation of lipid layer thickness may be considered in mask associated dry eye patients. Thank you.
So this is done only for a period of 8 hours.
The pre and post intervention after 8 hours with or without taping. Yes, sir.
There's a lot of work also being done on taping so that the microbiome of the ocular surface doesn't change due to the expired air that is comes up from your nasopharynx, which typically has a different bacterial different agents inside compared to our skin, nose, eyes. So everything is quite delicately balanced.